I would like to introduce Dr. Shereen Ezzat. Dr. Ezzat is a clinical scientist with a focus on endocrine oncology. Dr. Ezzat research focuses on the genetics and epigenetics of the neuroendocrine development and tumor genesis. Whoa! With more than 250 original research articles and has spoken over 200 invited lectures nationally and internationally. Dr. Ezzat sits on numerous professional societies of Endocrine Society, Federation of America Society for Experimental Biology, Pituitary Society, American College of Physicians, and Royal College of Physicians and Surgeons in Canada. I would like to welcome Dr. Ezzat on a presentation on Acromegaly Registry that is now happening in Canada. And I am over the moon excited about this registry because we need it. Please welcome Dr. Ezzat.
Thanks so much for the kind words. I am excited too. The fact that she's mentioned all these numbers is not a measure of my productivity, but rather my age. And as you can see, I've been around for a long time. And I've been around long enough to be able to remember seeing something like this. This is the textbook description or the image of acromegaly, which in Greek means enlargement of the extremities. And I want you to think about this very carefully, and the reason why I actually put a picture of an old image is for a very specific reason. This is the most archaic way that medicine is practiced and has been practiced for many years, which is to say, we will make a diagnosis when it's well past its due time. Very much like we will diagnose pregnancy when a woman is in labor. We will be 100% right, but most women, I think, would rather know a little bit earlier than that. And the reason for this is the following, is that most textbooks and most physicians have this concept in their minds that you have to have end-stage enlargement of the soft tissues and the bones, meaning that the patient will have suffered through many years, if not decades, until the diagnosis is made. And that is fundamentally wrong. And this is precisely the reason for my presentation today, is why we need to be able to have a registry, especially in a country such as Canada, where healthcare is very dispersed and relatively underdiagnosed conditions become even more problematic. Why? Because they're often not thought of. That's number one. And number two, access to care in specialized centers is extremely difficult. You can say, well, who cares? Some of you who do not suffer from acromegaly will say, okay, so you're going to have big hands and feet. So what? The so what is related to this. It's not so much what's on the outside that's a problem. It's what's on the inside that causes really a lot of havoc, because just about every organ in the body is affected in patients with uncontrolled acromegaly, from the heart to the lungs to blood pressure to physical changes. A lot of patients will end up requiring joint changes. I have patients in their 40s requiring hips and knees, sometimes even shoulders. By the time they're in their 50s, they've already had their second hip replacement. This is completely unconscionable. Diabetes, well, 1 out of 4 patients in Canada eventually will develop diabetes because of obesity. At the end of the day, not only is there increased mortality, which many conditions are associated with, but it's the impairment in quality of life that really becomes problematic. And one of the difficulties that I see as not just so much a physician, but perhaps as just another member of society, is that many of these individuals become so removed from society that their ability to become engaged successfully, to get jobs, maintain good jobs, maintain an income, maintain relationships, maintain all of the things that you heard about earlier that prevent this perceived sense of loss are at stake. I have patients who are not able to get into the subway because of this disfigurement, disability. They can't make their appointments because of that. And that's a huge issue. In this day and age, this really should not happen. What we try and do, obviously, is recognize that there are opportunities, because during this time of delay, when there is no diagnosis, there is a delay in intervention. There is a potential for intervention, which can be safe and effective. Obviously, what we want with the disease control is to reduce the heart disease, the bony problems, the diabetes, the hypertension, as well as the physical deformities. We want to prevent them. I don't want to see the patients when they're coming in that their hips are disfigured and their jaws are maloccluding. And now we're talking about having to do major operations, not just on the pituitary, but on all of these other complications. That's completely unconscionable, because at the end of the day, as I said, it's the reduction that we want to prevent and reduce the so-called comorbidities, associated conditions that really are quite severe. Now, you could say, well, it should be very simple, because anybody who's got enlargement of hands and feet should just simply have an MRI. Well, in principle, that should be the case. However, the vast majority of patients that we end up seeing look something like this. This is an MRI. The head is sticking out of a screen, or the ears are to the sides. The pituitary gland should be roughly the size of your small fingernail. This cauliflower-shaped structure is all now a tumor, with these holes being the carotids, the major blood vessel to the brain. This patient cannot be cured surgically, because you cannot enter into this area. This patient is now going to be committed to therapy lifelong, and may in fact require, in fact I can almost certainly tell you, is going to require multiple forms of therapy, including surgery, medication, radiation, and a few other things as well. So it's not quite so simple. And importantly, we also try to recognize, I don't know if you can dim the lights a little bit, but not all tumors on the MRI look exactly the same. And if you were able to see this a little bit better, you would actually see that this tumor, instead of growing upwards, is actually growing downwards. And this sort of aberrant pattern of growth should immediately raise the suspicion that there is something, thank you, I hope you can see that now. So you can see that the growth is going all the way downwards rather than upwards, which is really a reflection of a different type, a more primitive type of pituitary tumor, one that is not going to behave like the classical differentiated pituitary tumor. And Dr. Ezzat later this afternoon will talk a little bit more about this. But the important message here is that there are clues already, even in the imaging, not only that tell us about acromegaly. In fact, if you look closely enough, and you're astute, and I try and get my students actually to be able to appreciate this, this was actually a scan of a patient who had a car accident. And they were lucky enough to have a car accident to have the MRI done. And I show them this, and I say, what do you think? And they say, oh, well, we see a growth in the pituitary, but why is it going downwards? And I say, okay, but I want you to think a little bit more. What else is going on? And what I want you to be able to see is the skull itself, and you can actually see this jagged edge, what I called the rolled rug sign. The scalp is so thickened, and there are very few conditions that will do this, and one of them is, in fact, acromegaly. So just a glimpse from the MRI should be able to tell you this is a patient who has not only a pituitary tumor, but this tumor is growing aberrantly downwards,
and also has abnormal signs on the MRI that should tell you that there is functionality and an excess of some hormone. We haven't even done any blood testing yet, so we're saving the system a lot of money. What we do need is not artificial intelligence. I just need intelligence. The next thing is that, and you heard a little bit about functionality and non-functionality, and again, Dr. Ace is going to talk to you a little bit more about this. I'm often baffled by cases where patients have MRIs like this. So this is, again, is a tumor that's growing upwards. The patient really comes in, again, because of something else. In this instance, this patient is coming in because of loss of peripheral vision. They can't see to the sides. But that's really the tip of the iceberg. What's really not recognized is that this is a spectrum of tumors, of which one is the so-called silent somatotroph tumor. Now, what do I mean by that? What's a silent somatotroph? That means it's a growth hormone tumor, but it's not rip-roaring with excess of growth hormone that the patient literally is growing out of their shoes, but rather they have more subtle features of growth hormone excess. They have the fatigue, the sweating, the joint pains, the diabetes, the hypertension, but it's not quite so severe or flagrant enough, as in labor, but it should be enough to make somebody question the diagnosis. And that's what we refer to as a silent, not the rip-roaring form, meaning that pituitary tumors, even of the growth hormone type, come in different flavors, and each of these will manifest themselves clinically in a very different way that requires a very different approach in terms of therapy. So not one size fits all. This is one MRI that I had from actually the 1980s, believe it or not, another patient who actually got into a fight. And he got into a fight because somebody kind of made some reference to his appearance. And again, lo and behold, an MRI was done because he had a nosebleed. And you can see here, again, this is a large cauliflower tumor that's invading upwards. You can't even see the optic chiasm anymore, and it's pressing into his brain. Luckily, this was at a time when we were beginning experimental studies with an analog of a hormone called somatostatin. So this is back in the 80s. I was in California at the time. And that sort of taught me that really there's such a lag between what patients suffer from until diagnosis. And in fact, we completed a study across Canada with over 650 patients. And believe it or not, to this day, we still have a delay of at least 10 years from the onset of symptoms until the diagnosis is made, right here in Canada in this day and age. So even though we learned a great deal about how the whole system, and you heard a little bit about the circuitry, and I don't necessarily want you to know everything about how this system operates, other than, you know, there's a lot of pluses and minuses, and it kind of looks like a switchboard type of thing. We still have spent so much time and effort in medicine understanding these nuances of where growth hormone is made and how it's regulated and in different tissues and so forth, but we still haven't figured out how to get that information translated out into the world, into the communities, such that we know that if a woman feels something in her breasts, she's able to go right away, or if she feels something in her neck, she's able to bring that to the attention of a physician. But when it comes to something such as acromegaly, we haven't been able to make the headways that we need to be able to really make impact. And I'm being somewhat sort of hard on myself as a member of that medical community, so that even though we understand a fair bit on the mechanics of it and how we can work around it and how we can actually make patients feel better, we still haven't made the kind of progress that is required, thank you, to be able to get that message in a meaningful way to truly impact the number of diagnoses as well as the efficiency of diagnosis to be able to truly improve outcomes. So we still have to contend with a very old and I would say mediocre approach to pituitary tumors, where we still have to contend with how the tumor expands and causes headaches, how hormone excess causes all of the bad things I mentioned, and loss of pituitary, with many people suffering from all of the consequences listed here. This is something that we really have to work hard at preventing, and I would have to argue that there just isn't enough support for the idea of detection, early intervention for more effective approaches. So this is what happens. And I don't know if you can see or identify with this, but really it's kind of a circular, futile journey where the patient begins as maybe a blood test, the cholesterol is elevated, then they see a diabetologist because the blood sugar is elevated. Then, if they're really lucky, they might even be diagnosed with sleep apnea by another physician who diagnoses with sleep apnea and gives CPAP, for example. And then they hit their head if they're really lucky, and a neurosurgeon will find a tumor and goes in and removes it, not even thinking for a second that that patient has that diagnosis. So far, that patient has seen all these physicians going through this journey, which is probably taking years. And then afterwards, if we're really lucky, we're going to have a pathologist who actually knows what they're doing and calls up a neurosurgeon and say, by the way, you know that tumor you took out of that patient? It's got growth hormone in it. And the neurosurgeon will say, oh, no, that patient doesn't look acromegalic at all. He's not like the textbook that I showed you at the beginning. He was still wearing shoes. And as they say, if a shoe fits. And really the important thing is that that poor patient obviously is going to continue, and now they're going to be wedded to medical therapy after the diagnosis is made, and the journey continues, and then we go to a next line of therapy and another, and all of this in an attempt to be able to control not only the diabetes and the sleep apnea and the arthritis, but also the heart disease and the colon polyps, and the cycle keeps going on and on and on. And it's for this reason, and perhaps this is my introduction, these are almost kind of like the opening sequence of a movie, you know, sometimes it's quite really long. I get criticized for that, but I'd like to get the message across. This is the reason why we need a registry in Canada. And I just want to share with you how this was developed and hopefully how it's going to come into play. So first of all, in order to do this, really the idea is to bring a number of groups with common interests, and this includes scientists, clinical researchers, healthcare professionals, and of course also a number of organizations such as the one that you're listening to today, and also industry as a form of partnership, because at the end of the day we have to recognize that there has to be some common interests that come together to be able to really create what is referred to as an ecosystem. And more of relatively unusual or rare disorders are being managed in this way, is to be able to create registries with the help of different individuals and groups who really have that common and shared interest. And then from there, hopefully, what can come of this is the following. First of all, what has always been attempted is to make sure that the patient is part of that research so that their input is present, increasing research opportunities between the different specialties so they're not working in silos, which I think, as I mentioned, is a very important part, to be able to hopefully create a platform for clinical trials. And maybe if we're able to get philanthropy also engaged somehow to help support some of these efforts. So some of the benefits obviously is going to be an opportunity to be able to get support from hospitals. It's very hard for people like myself to go to a major hospital and say, we really need support for these rare conditions, because they say, oh, how many patients? How much money are we going to get out of this? That's sort of the immediate, and that's the type of pushback that we almost always get, and I'm sure you as patients have felt it as well. And that obviously becomes a problem, because then access to a number of resources, including novel therapies, and more importantly, adherence to standards of care, which I think is absolutely crucial. I believe that this is a very, very important factor in Canada especially. Many of you are or know people who don't necessarily live in downtown Toronto. And many people have to commute. And I feel so badly for many of these patients, including many of you who are in this room, because I know how hard it is to get downtown. And we're not going to be able to look after everybody and certainly not be able to see them as often as we would like. And it's for this reason we need to create shared care models out with the communities so that while a patient may need to have the specialized expertise centralized, it still has to be in conjunction with the local communities to be able to provide that continuity of care and ongoing services and access. But ultimately, that has to be standardized, because if every patient is getting a different treatment to different standards, that not only is it not fair, but it's really highly inappropriate. A patient who lives in downtown Toronto should be receiving the same as in Halifax and so forth. And of course, most importantly, we need to be able to continue to track the outcomes. How far off the mark are we? And I always tell my trainees is, we're doing things wrong until you prove to me that we're actually doing it right. How can we do it better? And we're almost always finding a gap. And this gap is related to a number of logistics, as us as physicians, as healthcare delivery, and as far as resources and many other impediments. And it's for this reason that it's absolutely critical that we track our outcomes. How far, not how well are we doing. It's a very different way, but rather how far off the mark are we? How can we make it better? So the registries go through a different process, and then you can say, well, it should be very simple. Maybe you're just going to create an Excel spreadsheet and have people fill that form, and it's going to be so simple. Well, I'm not an expert, but I have over the last few years now in working with Data Affinity, which is the company that actually works specifically on developing these databases and registries. They go through a very didactic type of process where people come together from different parts of a country with different expertise, and they make sure that they really all understand why they're doing it, become engaged, define the team, determine how the data is going to be derived, and obviously go through the process of the design of the collection of the data, and ultimately collect it, and then obviously work with it to be able to use it on an ongoing basis. So it is a process. And in particular, at this point, we've gone through these steps here already for acromegaly in Canada, and many individuals from across both English and French Canada have gone together, and we've reached this stage now. We're in the final phases of, I'm going to show you a little bit more about the actual design of what we've agreed on, and we had input from many different individuals, specifically with expertise, as I said, in different parts of this whole process. And the primary purpose of the registry at this point, we agreed, is to be able to characterize. Well, first thing is we wanted to get lay of the land. We want to know, first of all, very simply, how many acromegalics are there in Canada? How many are diagnosed? And then we want to go to how many would we normally expect. Now, I want to get back to something that's been said earlier. So, you know, incidence is new cases and prevalence is existing cases. And whenever you see somebody saying 3 in a million, that's kind of like a standard clause in the lingo of the industry, which means I have no idea. So always be wary about 3 in a million. It's kind of like when somebody tells you, oh, you're so special. You got to be careful. I'm quite cynical about this. But most importantly is that we have also secondary outcomes. We want to be able to know how can we get to decreasing the time to diagnosis, because we want cases to come in well after they're in labor. We want them much, much earlier than that, to be able to have tumors that are resectable, that are more contained before the damage has already gotten to be so extensive that it's hard to reverse. We want to obviously increase the number of diagnosed patients. This is going to be an increase in prevalence. And some government bodies don't like that sort of thing, because when you increase the prevalence of any condition, that means, oh my goodness, we're going to spend more money. So then we have to fight with these bodies to be able to convince them diagnosing the patient doesn't cost more money, because those patients are still out there. They're circulating in that pool. If anything, they're utilizing more resources, they're having more tests, they're using more drugs, and doing it less efficiently and less specifically. So just because they now have a label and they're captured in a streamlined fashion does not mean they're costing the system more money. If anything, it actually probably costs less. Furthermore, if I can actually improve the quality of life of these patients, I can get them better integrated into society, have them being more productive, have fewer people who are on disability. So at the end of the day, at every level, I can make a very strong argument that it's actually making more financial sense, even if you don't care at all about these people. So improvement of when I say quality of care, I'm not talking about better blood pressure control or better diabetes. Of course, I want all of these things, but I want a lot more than that. I want people who are better integrated into society, who can become more normal in every aspect of their lives. This registry is going to have a steering committee, which has already been recognized. These are Canadians, all Canadians who deal with such patients, as well as obviously representatives from patient organizations. And these are the steps here with the steering committee. Number one, the gathering the data was already started in the Canadian registry, starting in Dalhousie. I should also indicate that this is part of a larger international effort, because if we're really going to make a difference, one of the things that we also want to do is to be able to get other countries who are in similar trouble, like us. Notice we're talking about European, not American. Part of a reason for that is because the American system is so incredibly different from ours, and it's very, very hard to work with them because of the nature of the system. So really working more with more socialized networks such as ours. The steering committee also has gone through evaluation of many of the components of what's going to be captured, and ultimately 30 patients were recruited, and this is just sort of like as a pilot, if you will. And the idea here now is we've reduced from a huge body of information, because one of the things that we argued about was, you can imagine, everybody wanted this piece of information, and how many kids did they have, and when did they have the kids, and I was kind of like saying, guys, can we just try and make it a little bit simpler? So I did have one possible small win, and that is to reduce the number of items here to 68 clinical items, to make it a little bit more practical, to be able to capture the information. And more importantly, what I really argued for very strongly is to make sure that the information is authentic, that it is not quasi where it's questionable and the quality of the data is. This is just a screenshot of what this would look like. And the idea here is that every visit, when a patient comes in, for example, on medications, we want to be able to capture what are they taking. We identified the different classes of medications, yes or no. And then we also built in the unknown, which unfortunately is part of what happens in real life. Sometimes the information is just not available, which is something that obviously we try very hard to avoid. Here's on the patient demographics. Again, how old is the patient, when was the diagnosis made, and what were the presenting symptoms, as you can see here, from excessive milk production, breathing difficulties, and so forth. So in other words, trying to capture why, because we hope at the end of the day, if we can crystallize this to the point where we can say, you know what, if you present to a diabetes doctor and you have 1, 2, or 3 of the possible items, maybe you should be thinking of something as unusual as acromegaly. And if we can get that disseminated based on data that is captured in our medical system, then perhaps we can be able to identify these patients. And we haven't even done any blood tests yet. We haven't cost the system a penny. All we're trying to do is to be able to say to physicians, general practitioners, respirologists, and diabetologists, just think of a diagnosis. It will take you less than 5 seconds. And if you think about it, then obviously life becomes so much easier. But if you don't think about it, no blood test, no scan is ever going to help you or be worthwhile. These are clinical sites for the initial launch, as shown here. And you can see that it's across the country. And ethics documentation is currently underway. People still have to be able to approve this and give consent for the information, which obviously is going to be anonymized, so there's nothing specific or personal is going to be in any way captured or returned back to affect them in a negative way. I should add, obviously, that one of the sponsors has been Pfizer, that provided unrestricted educational support, and through the help of Data Affinity, which is the company that has been working, and they have, as I said, recognized long-term expertise in creating patient registries for other rare conditions. So the idea here ultimately is to be able to integrate this with other registries, as I mentioned, Canada, right here, with the other European countries, and then hopefully we can align them together to be able to get larger data, putting them together and aligning them, which hopefully will align us in such a way that there can be not only standardization of care within the country, but across the world, hopefully. So the next steps is to be able to get to the physicians from across the country, enter clinical data, have patients also participate and want to participate. We want to be able to get you guys involved for the reasons that I mentioned. So right now, we're waiting for ethics approval, as I said, before the launching can take place. We want to make sure that everything is being addressed and all of the details are taken care of. And most importantly, I want you guys to be involved in the so-called beta testing, which is to make sure that this system is well-oiled, and if there are some significant problems, that we're able to work them out so that we can address them and revise the methodology in such a way to make sure that we're not missing anything. This is the website to be able to get access to information about how you can do this. And of course, hopefully there will be other emails, and once you register, you'll be getting notifications as this process continues. I want to emphasize, though, at the end of the day, it is a team that works together, and you are at the center of a team. You're the captain. Yes, there are some endocrinologists, and sometimes they think too much of themselves. They're probably just the guys who stand in the back and say, yeah, of course I knew that. Most importantly, I actually think that the endocrinologists are basically like the intermediate individual. I feel like I'm a broker. What I have to do is assemble a team of those who really do the work. And if I am good at what I do, I bring people who are much better than me, as radiologists, as pathologists, as neurosurgeons, radiation specialists, and endocrine nurses, all of whom come together because they have not self-professed expertise, but rather I have helped them recognize where the deficiencies are. And that, over the years, is what allows people to be able to actually get better, to be able to deliver the better quality of care that's required. It is not one where people say, we are a center of excellence. That's probably the most arrogant and useless way of recognizing how not to be. What I want is a system that continually and perpetually tries to challenge itself, improve itself, for the reasons that I mentioned, because quite frankly, when it comes to conditions such as acromegaly, we're far, far behind, and there's a lot of work that needs to be done. And I hope that what I've done is giving you sort of a perspective of what I think can actually happen. Thank you so much for your attention.